Bismillahirrahmanirrahim. Assalamu alaikum. Today we will talk about the management of otitis media with effusion. In part 1 we discussed its etiology, clinical features and investigation. The link for this part 1 is there in the description, so you can check it out. Let's see what we have got for the management of a child with otitis media with effusion, which is also called as serous otitis media. This treatment will depend upon the severity of the symptoms, of course, and we should keep in mind the spontaneous resolution of the disease, because in more than 90% of the cases spontaneous resolution is the rule. So we should wait for at least 90 days before embarking upon any kind of surgical intervention, and in the meantime only explanation of the disease and reassurance to the parents about the ailment of the child is what is required. A review visit after 3 months, and then we can establish whether there has been a spontaneous resolution of the disease. But if there is persistent nature of the condition, in a particular a persistent hearing loss, then we have to think about some alternative treatment plans. In the management, we have got three main cornerstones. As far as the medical treatment is concerned, it has got a very little role to play. Though some people have used low dosage antibiotics for long term, claiming that it has got an effect. But those opponent to that, they claimed that actually they were giving these antibiotics to those group of patients who were going to be spontaneous resolution of the disease, even if this low dosage antibiotic was there or not. Then autoinflation of the eustachian tube, because in pathophysiology we noted that this is the eustachian tube dysfunction which plays a pivotal role in the causation of. So autoinflation of the eustachian tube using autovent devices is of utmost importance, and those very few, less than 10% of the cases who present with persistent hearing loss even after 90 days, in those cases we can think about meningotomy or meningotomy with Grommet insertion. So this is the autovent that the child is instructed to inflate the balloon. One nostril is closed and one expired air comes into the nasopharynx. It goes towards the eustachial tube and it tries to open it so that eustachial tube patency is restored, leading to the aeration of the middle ear cavity, which was compromised by the blockage of the eustachian tube. So as far as medical treatment is concerned, we have got different options, but as I said that actually no significant role, but still, because eustachial tube dysfunction is the underlying cause, so we can think about the systemic or local nasal decongestants. We have got pseudoephedrine, we can go for triprolidine or phenylpropanolamine. Locally we can use oxymetazoline or xylometazoline nasal drops for short-term duration. Those people who are using it, they claim that it speed up the resolution. Even I just mentioned that people have used low dosage antibiotics, but as it is a sequelae of the acute otitis media, so maybe they have got some role in initial 1 week or 2 weeks, but long-term usage is not recommended. Nasal decongestants, again, you can use them. Mucolytics, plus minus, is their role. Then people have gone in favor of corticosteroids. Those are in the form of nasal sprays or oral steroids, but still their role is not that much helpful in the treatment of this disease. Autoinflation, yes, it can improve the condition 3.5 times more and a higher efficacy is in older children, because older children can perform these autoinflation procedures very well. Then if nose is the causative factor which indirectly cause the justitial tube dysfunction and there is allergy, we can use anti-allergy drugs. Middle ear aeration can be done by Valsalva maneuver. We can ask the patient to exhale against the closed nose and lips so that expired air goes towards the justitial tube and tries to open it, or we can use politicization. But if those persistent cases in which there is no improvement, we have to think about for some surgical intervention, because there is fluid retention in the middle ear. So we can go for simply the meningotomy. As the name indicates, it means making an incision in the tympanic membrane and to remove that thick tenacious glue like fluid in the middle ear. Or if we think that the justitial tube dysfunction is not restored immediately, or it is not expected to be patent, then we can think about meningotomy with the ventilation tube insertion, which we call as grommets, so that the aeration of the middle ear cavity, which is jeopardized by the justitial tube dysfunction, now this aeration will be through these ventilation tubes, and atmospheric air from the external ear will be conducted through these tubes to the middle ear cavity. So grommets we can use, or there are T tubes also if long term we have to use. And then if the patient is having associated adenoid hypertrophy, we can think about adenoidectomy. Tonsillectomy in isolation is being said not to play any significant role in the improvement of the disease, but yes, if there is adenotonsillitis, recurrent adenotonsillitis, then we can go for adenotonsillectomy. And if there is fluid there in the mastoid air cell system, then we may have to plan the cortical mastodectomy. And there are some research methods, that is the percutaneous mastoid ventilation following the chronic mastoiditis, or chronic carbon dioxide laser can be used to make small 2 mm small circular perforations in anteroinferior quadrant for the adult otitis media with effusion. Adenoidectomy, some research papers they have published that the size of the adenoids is not actually the indication, because there is no significant difference between the occurrence of otitis media with effusion in patients with normal sized adenoids and with the enlarged size of adenoids. Others who are against this, they say that adenoids hypertrophy can mechanically obstruct the justitial tube opening. But yes, as a source of infection, if repeated adenoiditis is there, then it can cause the inflammation of the justitial tube opening. But anyway, at the end of the day, adenoidectomy is being done in such patients, and it has got some significant role. So this is a normal tympanic membrane. If we have to do the meningotomy we will do in a radial incision, which will be in basically separating the radial fibers of the middle fibrous layer, and a thick gelatinous glue-like fluid will be oozing out from this incision. This is a meningotome or meningotomy knife, and with that we just incise the radial incision in the anteroinferior quadrant of the tympanic membrane. And if we think that justitial tube function or its patency could not be restored in immediate future, then we can go for meningotomy with grommet insertion. These grommets, these are basically the ventilation tubes. Here you can appreciate a small hole. It is just like a stud, that two peripheral parts or hubs, they are larger and they are attached with one another with a small stalk. So one part will be there in the middle ear, other one will be here outside in the external auditory canal, and through this hole the external ear air will be conducted to the middle ear, so that middle ear aeration will be there, which is compromised due to the justitial tube dysfunction. So this is basically, you can say, a bypass procedure, bypassing the function of aeration which is being carried out by the justitial tube normally. So these are different types of ventilation tubes. You can see in the picture, these ventilation tubes are grommets. They are in situ. So grommets, they usually stay up to 6 to 12 months and then they are being extruded automatically. If not extruded, then surgically we have to remove it. In those cases, especially in adult type of otitis media with effusion, which is secondary to the treatment of nasopharyngeal carcinoma, and treatment of nasopharyngeal carcinoma is the radiation. And there we know that due to the fibrosis of the eustachial tube, its patency may not be restored. So there we can go for what we call as a T tube. T tube, it has got a long prongs. So those long prongs are there in the middle ear cavity. So its extrusion is not within an year, rather it stays there for a longer duration. These ventilation tubes, they are made up of different materials: silicone, Teflon, then stainless steel, titanium, and even gold made these tubes are available. Different names are there, different shapes are there, but most commonly used is the Shepherd or Shaw's grommets, and then Armstrong, even Reuter Bobbin, Goodall, and these are inserted usually into the anteroinferior quadrant of the tympanic membrane. So these are different types of grommets along with the mild differences in their shape. This is Armstrong, this is collar button, this is mini Teflon merangotomy tube. Most commonly which are used, as I told you, it is Shaw merangotomy tube, or this is the Shepherd merangotomy tube. This is T tube, which can be used if we are expecting and we are hoping for it stay for a longer time, because all other these grommets, they are extruded automatically within an year. From 3 months to 12 months is the duration, depending upon different factors. But this T tube, as you can see, it has got a long prongs which goes medially into the tympanic cavity, so it stays for a longer duration. This is an umbrella merangotomy tubes. So different tubes are available, but as I told you, Shaw's grommets or Shepherd's grommets are the most commonly used for otitis media with effusion, and T tubes are being used where we expect a longer stay of this ventilation tube. So of course they will improve the hearing immediately, and there will be shortens the overall duration of the condition, and this benefits may be augmented by adenoidectomy if adenoids are there and causing symptomatology. Grommets should be used, as I told you, rather than the T tubes, which are associated with an unacceptable high rate of residual perforation because they stay longer. So in 50% of the cases, after removal of the T tube, there will be residual perforation. So this is the sketch of normal tympanic membrane, and here in this lower picture you can see that there is grommet insertion here. This is grommet in situ. You can see very clearly the grommet is there in its place, and this is the hole in between through which aeration of the middle ear cavity is being carried out. This is the hole. This is T tube. As you can see, it has got a longer end here, and inside there are two ends. One is going like this, the other prong is going like this. So naturally it will stay longer and its extrusion will take time. This is grommet extrusion is being taking place now. So complications of the grommets, as you can very well assess, infection can occur there if proper sterilization is not there. So it should be treated by oral toilet and antibiotics, but grommet removal may be if condition fails to settle. In 30 to 40% of the children, after 1 year, when grommet has been extruded, there can be a whitish patch in the tympanic membrane, which we call as tympanosclerosis. So here you can see The grommet is there in situ, but you can see the congestion and vascular markings. So it means that infective process is going on here in this particular case. The grommet has been extruded. You cannot visualize the grommets, but there are whitish patches in the tympanic membrane, which we call as tympanosclerosis. And it makes the tympanic membrane thick and its movement difficult. So that naturally there may be some kind of hearing loss. So complications, in addition to those infections and tympanosclerosis which we just mentioned, there can be displacement of the grommet into the middle ear, or there can be damage to the ossicles of the middle ear. Then during procedure, then early post-op, there can be blockage of the tube by the blood, because that lumen which is there in the grommet, that can be blocked by the blood, and the purpose of ventilation will be hampered, so that it should be cleared off, or there can be granulations around the tube, ear infection, and leading to ear discharge. And later on, after extrusion, there may be permanent perforation or residual perforation, especially with the use of T-tubes, in which we have noted that in 50% of the cases will be having a residual perforation. Then there can be tympanosclerotic patch, which is a thickened tympanic membrane, whitish patch is there, or in contrast, there can be tympanic membrane retraction, and tympanic membrane atrophy can also occur. Little aftercare with grommets in situ. No good evidence that swimming with unoccluded ears increases the risk of infection, but still the patient should be advised to use earplugs during swimming and bathing. Grommets extrude from 3 months to 12 months, and after that the review is required to check up the hearing, especially the audiological tests should be done. A sizable proportion, like 25%, will require subsequent further grommet insertion, that there may be again reaccommodation of the fluid, so that they may also need a repeat procedure. Sequelae of otitis media, there can be adhesive type of otitis media leading to tympanic membrane atelectasis and tympanic membrane atrophy. When atrophy and retraction is there, retraction pockets can form, and retraction pockets can lead to the formation of cholesteatoma. Ossicular necrosis in very rare cases, and then tympanosclerosis, that is the whitish patch there over the tympanic membrane. Any queries or any questions will be welcomed in comment section. So here I leave you with some MCQs so that you can check these MCQs and you can assess yourself. So question is, the tympanic membrane from outside appears as, that when we are doing otoscopy, we are looking at the tympanic membrane from external auditory canal. How does it look like? Is it concave? It is concavo-convex? It is convex? Or it is just plane at right angle? It is being placed at the end of external auditory canal. So this is question 1. I would love to see your answers in the comment section as well. Cone of light lies in which quadrant of the tympanic membrane? We know that the pars tensa, we divide it into 4 quadrants by 2 imaginary lines. One vertical imaginary line is passing through the angle of malleus. Another imaginary horizontal line is passing through the umbo, and so that we divide it into antro-inferior, antro-superior, posto-superior, and posto-inferior quadrants. So cone of light lies in which quadrant? Question 2. Question 3 is, otitis media with effusion may occur in any of these except inadequately treated otitis media, carcinoma of the nasopharynx, cleft palate, cancer of base of tongue. Sequelae of otitis media includes all except retraction pockets, cholesteatoma, ossicular necrosis, thickened tympanic membrane. All of the following are true of otitis media with effusion except conductive type of hearing loss, restricted mobility of the tympanic membrane, normal bone curve on audiometry, normal X-ray mastoid. This is SCQ. Try to solve it. A 5-year-old child is very slow in developing speech. On otoscopy, he has got dull tympanic membrane, horizontal handle of malleus, and prominent short process of incus. What is the diagnosis? And how will you investigate and treat the patient? Subscribe the channel so that you got notification in time of future videos. Like and share it with your friends if you think it is beneficial for you. So share it with your friends. They can also get benefit of that. Thanks for watching.